Okay, we're gonna go ahead and get started. Can everybody on Zoom hear me? Yes. Yeah, cool. Okay, so thank you all for coming. This is the second part of our lecture series. Today we're going to be focused on privatized healthcare and organized capital. So the way this is going to work, the first half is going to be led again by Dr. Ed Weisbart, talking about Medicare Advantage and the privatization of public health insurance programs. I'm going to have a couple of quick slides, and then we're going to turn it over to Kellen Gildersleeve, am I saying that correct? Who is from the Ascension Seton Nurses Union to talk about organized labor and community organizing. So kind of real quick, everyone Zoom in person, if you have not signed in, please do so. It's really going to help us kind of like track our attendance and figure out how effective these are, because we're going to do some more comparisons. We'll leave that up for a quick second. Cool. Okay, next slide. And again, just as a reminder, this, like I said, is the second session out of our 5 lectures. So you can see next week will be the third lecture about COVID-19, what happened and what didn't, focusing on whether or not the pandemic was actually a rallying moment for change, and kind of the effects of that. And then universal healthcare, what it can and can't solve. So focusing on, if and when we do achieve a universal system, what problems are we still going to be left with, and what problems are going to kind of be helped by that? And then lastly, a path forward. So talking about how do we actually achieve Medicare for all? What are the different considerations? Where do we actually go from here? So yeah. And then these again are just the learning objectives for today. Like I talked about, focusing on privatization of Medicare, community organizing are kind of the big components of today. So yeah, with that, we're going to stop there. So stop sharing your screen. We're going to turn it over now to Dr. Ed Weisbart for his presentation.
Hey, thanks. And thank you for inviting me back. I guess I didn't do too badly last time. So, lot to talk about, and I love the agenda that you've got for the whole course. Today we're going to talk, or I'm going to talk a bit about what was the first large frontal assault on our public health program, Medicare. So that's called Medicare Advantage. So we'll unpack what that is. And I think after a few minutes of that discussion, you'll already know more about what Medicare Advantage is and isn't than probably most people in the country. It's amazing how people don't quite understand what that program is, and your patients are making major decisions about how to approach this. So I'm really glad to get a chance to talk about that with you. And then that'll take the bulk of my time. Then we'll talk about the more recent, hopefully smaller, but potentially even larger attack called ACO Reach. And we'll just cover that kind of briefly with a bit of really good news about that. So that's kind of the run of show. That's what I'm planning on talking about. And let me show you some slides, which I believe you can now see my slides. Yes? Yes, good. I saw a hand going up there. Okay, so that's what that's kind of the run of show. But to maybe start that, let me introduce you to someone in my family. In truth, this is the only reason that I do these kinds of talks, is because I like looking at a picture of my mother-in-law. And there she is. And if you're a HIPAA cop, not to worry, I have my mother-in-law's permission to tell you this story. So there she is. Raise your hand if you agree with me that that's the most beautiful mother-in-law you've ever seen. Yes, hands, no. Good, you did. Yeah, okay, excellent. Okay, so Ma lives in Ormond Beach, which is near Orlando or Daytona in Florida, and she has Medicare. She's had it since she turned 65, and she has a supplement. She's not in Medicare Advantage, and I'll explain why that's so important and why she's illustrative of why we're concerned about this. She has traditional, good old-fashioned Medicare, and as you recall my speaking last time, traditional Medicare is a synonym for original Medicare. You hear people say those two things, those are synonyms. And last time we unpacked what Medicare Part A and B are, all traditional Medicare, and that's what she has. She has traditional Medicare. And with that, she can go anywhere she wants to go for her health care. She has HOCM. She has a pretty rare, frankly, in a geriatric population, genetic problem with her heart, which is ultimately fatal, and about 10 years untreated. About 10 years ago, it kind of started to act up, and then maybe 3 or 4 years after that, she was frankly desperately sick. And it turns out that there's only 3 places in the entire country that have a specialty in treating hokum in seniors. There's only 3 places with any real experience. One of them is not in the entire state of Florida. No, one of them is here in St. Louis at Washington University. So she has traditional Medicare. We flew Ma from Florida all the way here to St. Louis. She spent most of a week in the hospital, got arguably world-class care, and stayed for a few weeks kind of recovering, and then went back home and did terrifically. And she didn't, I'm kind of the bloke who managed that process, and I never called anyone to get permission, didn't have to get it prior authorized or anything of the sort. We decided where in the country was the best place for her, and we took her here for it. When she was here, she had nothing to pay. She has a supplement, and it made all of her copays disappear. When she went home, she was not among the legions of people who go home from the hospital and then have a pretty large bankrupting surprise medical bill. She didn't have any of that because she has Medicare and a supplement. And she's confident that this program is going to be here for the rest of her life. So if you want to try to disrupt her Medicare, you have to deal with this. And I'm pretty sure you don't want to deal with that. I have. You don't want to deal with that. So what is this? What are we talking about? I'm emphasizing how important it is that she has traditional Medicare and that she doesn't have Medicare Advantage. Why is that such a big deal difference? So what is that? Last time we talked about what traditional Medicare is, we described it as being very simple and very efficient. Basically, you pay your federal taxes and you get your precious red, white, and blue Medicare card, which you hold on to for dear life. And then Medicare pays doctors and hospitals and most of the rest of your healthcare. So that's how traditional Medicare works, with a 2% overhead. Medicare Advantage is completely different and far less efficient. So instead of having essentially the government manage the finances behind the scene, instead, interposed between Medicare and physicians and hospitals are all these insurance companies. And Medicare then has to have a contract with each and every insurance company that's involved in this. So already you can see it's more complicated. And then each of them have contracts with each and every physician who is in their network. And that's yet another level of complexity. And of course, it's not even that simple, because the insurance companies say, oh, you can go to this doctor that's in Medicare, but not that doctor who is also in Medicare. You know, they tell you who they want you to go to and whom they do not want you to go to. So we're essentially paying the Medicare Advantage insurance companies to tell us which doctors and hospitals we can't go to. Why we would set up a system like that makes zero sense to me, but it's fundamentally more complicated, as you can see. And if you've studied quality improvement in any other venue, Edward Deming's work on it, you know that the essence of quality improvement is simplifying the workflow. This is fundamentally more complicated. This is where you start getting all those HMO style tools that most of us despise, prior authorizations, step therapy, all the craziness that we don't like. This is, of course, if you're in Medicare Advantage, you have a much smaller network. Medicare Advantage plans don't want you if you're among the sickest of Americans, because then they have to pay a lot of your bills, and they want you if you're healthy. Because remember, they're paid per person a fixed dollar amount monthly, prepaid. They're capitated essentially for your care. So then if you don't need any care, they get to keep profit. And if you need a lot of care, well, then they may have to spend more than what they were prepaid for. So they don't want you the sicker you are, and they do want you the healthier that you are. That all results in very high profits for them, which I'll show you. And of course, just looking at the complexity of arrows, among other things, a tremendously high overhead. And what I don't think people are realizing enough yet, but which is starting to get recognition, is that these are companies that tend to have pretty high levels of accusation, fine, and settlement for fraud. So despite those concerns, Medicare Advantage is growing, and it's frankly now pretty close to 50% of people in Medicare. And you largely have to sign up for it. You're in Medicare, and then you see the ad on TV, And most people who are in it are in there because they saw the ad, they kind of got tricked into that, which I'll show you in a few minutes. Sometimes it is actually a sensible choice, and we'll show you that too. But they had to generally sign up for it and give up traditional Medicare. Some employers and such that have retirement benefits are actually moving in block over to it. But for the most part, people are there because they chose to be there. And Congress sees this as proof that it's, what is that so messed up? Congress sees the growth of Medicare Advantage as proof that seniors like it. And in fact, last year, a strong majority of Congress wrote that the growth of Medicare Advantage is proof that seniors are happy with the coverage and the quality of care. They may as well have said that this is a market economy and the Medicare Advantage is growing, and that proves that it's better and that seniors love it. So it's growing. Is that because it's better? Well, one of my heroes, Dr. Don Berwick, former administrator of Medicare, had a different take on that. He said he dealt with the fact that Medicare Advantage is paid now roughly 6% more per person than traditional Medicare spends on it. In other words, Medicare Advantage is fairly heavily subsidized extra beyond what traditional Medicare costs. So he says the growth of Medicare Advantage can be explained in this way. If an ice cream firm can offer free ice cream because of a subsidy, well, then its market share will, of course, grow against firms that have to charge for ice cream. That's not because it's better ice cream, that's because it's free ice cream. And indeed, I'll show you that that's exactly what's going on. So we overpay them, and that's in part to help them deal with their incredibly high overhead. So any of the charts that have numbers on them, as does this one, there will be a footnote at the bottom with the public domain or peer-reviewed kind of source. So the most recent SEC data that I've seen shows that they have about a 15%, let's say, overhead and profit, whereas traditional Medicare Parts A and B operates far more effectively efficiently with only a 2% overhead and, of course, no profit. So how do they make their profits? They do it in part by rejecting care that Medicare itself would declare is necessary and appropriate. They reject it. So Medicare has guidelines that are evidence-based, nationally available, and Medicare Advantage firms, unlike Medicare, Medicare Advantage firms put in requests or put in barriers to getting care called prior authorizations. So for a bunch of things, CAT scans, MRIs, various procedures like my mother-in-law had, you can't just go get it if you have Medicare Advantage. You have to have this new insurance company, the Medicare Advantage insurance company, approve it or prior authorize it. That almost never happens in traditional Medicare. They don't do that very much. They got like 5 things that they do that for. Medicare Advantage, does it for almost everything that's expensive. So they deny things, and it turns out that 13% of the things that they deny are things that Medicare has declared would have been covered were the patient in traditional Medicare. So it's of the ones that actually get appealed. The denials would have met traditional Medicare. And if they deny payment for it, nearly 1 in 5 times when Medicare Advantage companies say, no, we're not going to pay for that, even though they've been prepaid by tax dollars for it, 1 in 5 times they say, no, we're not going to pay for that. Too bad. Actually, Medicare has determined that roughly 20% of those denials or that they refuse to pay for are things that Medicare would have paid for. So they're medically necessary. These are secret proprietary coverage rules. They are not things you can look up on your own. They are not part of the coverage rules that Medicare has. And in my mind, that's just quaintly 2019 that they wrote these things, because now it's a little bit different. Oops, put it in there. Because now it's different. Now these quaint little 2019 human-driven coverage rules are now a big source for artificial intelligence. So we're reading more and more that artificial intelligence is writing the coverage rules. Artificial intelligence is reviewing your clinical state against the coverage rules that they wrote, that the AI wrote, and artificial intelligence is doing some of the appeals when you complain that it's not covered. So this whole world has gotten more bizarre. And as a result, Medicare Advantage patients have cost-related problems getting access to care. So if you ask them, If you compare people in traditional Medicare who have Medigap, and we'll unpack why that's important, Medicare is flawed in ways that Medigap really fixes. So if you compare people in traditional Medicare with Medigap versus people in Medicare Advantage, you find that people in Medicare Advantage are far more likely to have cost-related problems accessing care. Not quite as much, with a similar ratio if you're white, if you're Hispanic more, and if you're African-American, pretty strikingly. So people have difficulty accessing healthcare for cost-related problems when they go into Medicare Advantage, even more difficult if their health is compromised. And that's part manifested by the fact that Medicare Advantage won't let you go oftentimes to top-rated cancer centers. So if you compare these sorts of procedures, if you need an appendectomy, probably most general surgeons at most community hospitals are perfectly skilled and competent at that. But if you need one of these kinds of things, an esophagectomy, Whipple's procedure, if you need one of these things, you want to be sure you're going to someplace that's got really good experience with it. And yet people in Medicare Advantage, because those kinds of hospitals are often not covered, are much less likely to go to a top-rated cancer center for their surgery and for other things as well. And as a result of that, people tend to want to leave Medicare Advantage when they get sicker. So before the final year of life, roughly less than 2% of people actually do switch back from Medicare Advantage. But in the last year of life, people are far more likely to switch back. And the reason that they are is because they couldn't access specialty care. They couldn't access specialty care. And so how do these companies make money? Well, first by fraud, and there's frankly, tens of millions or hundreds of millions of dollars for most of the large companies have massive settlements and fines and penalties for fraud. And they seldom admit guilt. You'll read that in the paper oftentimes, such and such insurance company settled hundreds of millions of dollars for fraud without admitting guilt. And they don't admit guilt, they settle, because if they actually admitted guilt or took it to court and were found guilty, then you could probably keep them out of participating in a federal program. But these aren't admissions of guilt, so they pay the fine and they keep on playing. They also want to attract the healthiest, as we talked about. That's one of the ways they make their money, and they lemon drop the sicker people. So we talked a little bit about that. And then lastly, upcoding, essentially fake diagnoses. They want to add in. So in traditional Medicare, right, when you submit your bill to Medicare, you're paid based on what procedures you said you did. So you did a moderate level office visit, you get paid for that. You coded for that. You did a complicated office visit, you pay for that. You removed a cataract, you put in the code for a cataract surgery and you get paid for that. That's not how Medicare Advantage companies are paid. They're paid prepaid, capitated, supposedly more if they have a sicker population. So the game in Medicare Advantage is to get paid more from Medicare by making people look sicker. So they do house call. They have a nurse come out and does a house call and collects extra diagnoses that aren't even being treated, just so that they can rack up diagnoses and make you look like you're sicker when you're in Medicare Advantage. They pressure physicians to upcode and add more diagnoses. Well, this person had back pain 35 years ago. They sure include that so that we can upcode the diagnostic codes and therefore get more capitation dollars from Medicare. That's a game that happens in Medicare Advantage. And that game is worth tens of billions of dollars, just the upcoding. Now, I'm not talking about the cherry picking or the lemon dropping or the fraud. Just the upcoding is worth tens of billions of dollars a year. And they've never generated, and on net, it stays favorable to the Medicare Advantage firms. They've never been able to demonstrate that they save money for Medicare, ever. This is the Kaiser Family Foundation, and it was actually just repeated a few weeks ago in the recent MedPAC report. This overbilling is huge. If you look at the dollar amount that we're talking about for 1 year of Medicare Advantage overbilling, it's more than the budget of NASA, the entire National Aerospace Program. These are, and we talk about, whether or not we'll renew CHIP, Children's Health Insurance Plan, because it's so much money. We have these arguments about all these other things on this list, but Medicare Advantage, just the overbilling, it's a real amount of money, $1 billion here and $1 billion there, and it starts to add up. Okay, so if you can't get access to care when you need it, if you can't go to the doctor you want to, and if you have, higher out-of-pocket expenses, what, why, especially when you're sick, why does this exist? Why do people sign up for it? Well, they sign up for it because it addresses some of the major flaws in traditional Medicare. As we mentioned last time, Medicare comes with a 20% outpatient coinsurance. It comes with a $1,600 deductible per hospitalization. So if you're sick, you might be hospitalized 3 times in a year. That's more money than most folks can find. And on traditional Medicare, there's no maximum to how high that can go. So imagine somebody that's got some serious problem and goes to see a physician, once or twice a week, and maybe is hospitalized to her. It's going to bankrupt you. So if you're sick in traditional Medicare, you actually do have risk of being bankrupted. And then that's not counting the fact that if you're in traditional Medicare, you have to pay your Part B premium, you have to pay your drug premium. And my proposal is that you would have to get a Medigap plan, which has its own premium. And I'll explain that in a moment. So if you're in Medicare, you really have 3 options. The first is to be in traditional Medicare and do nothing about it, ignore the risks that I just presented, and then you do have exposure to bankruptcy. Or Plan B, you could switch over from Medicare to Medicare Advantage, and we'll compare these in a moment. And then Plan C is maybe you would switch. I shouldn't call them A, B, and C. It's confusing. The third choice is you could supplement your Medicare with Medigap. So you hear me say Medicare, Medigap. Some people will call it a Medicare supplemental policy. Those are synonyms. Don't try to figure out the difference. They are synonyms. There are several of these, but almost everybody today who goes into Medigap, purchases Medigap today, purchases Plan G, as in good. So you don't need to learn the rest of that alphabet soup. Plan G is what most people have. And let's compare this. So I'm going to compare on the left people who have Medicare with a Plan G supplement with Medicare Advantage on the right. And the reason it's worth your knowing this level of detail is if not already, you will soon be seeing 64-and-a-half-year-old patients who are making this decision, or 70-year-old patients who are confused about how they got into this mess, or your parents or your grandparents or somebody in your family. This is information most people don't have, and it's really important. So the most obvious difference is that if you want to purchase a Medigap supplement, you have to spend about $200 per month. And that's, I think, exactly what I spend for myself, and then $400 with my wife. So roughly, what's 400 times 12? Nearly $5,000 a year is what I spend on supplemental policies. Medicare Advantage, well, the price ranges around the country. Here in Missouri, I could have joined Medicare Advantage for free. I could have joined several Medicare Advantage companies for free that would have included a drug benefit for free. The average of the country is about $18 per month to join Medicare Advantage. So there's one pretty big difference. Another difference is if you're in Medigap and you have, and once you've exhausted the deductible, that's it. You're not going to have, you don't have any more copays, no more. Once you've exhausted the $226 deductible, if you keep paying your premium, you don't have any other financial exposure for things that Medicare approves. So that's a big advantage of Medigap. Medicare Advantage, they can still charge you copays and deductibles. And if you need to go outside of their network, they can charge you up to more than $12,000 a year in out-of-pocket expenses. So, one hospitalization at someplace out of your area, and you could be out more than $12,000 in Medicare Advantage. Benefits, Medigap doesn't add any benefits beyond getting rid of the copays and deductibles. So Medigap doesn't add in dental or hearing, whereas Medicare Advantage often does. The ads on TV say, join Medicare. Did you know you're eligible to get your hearing tests covered by Medicare? Did you know you're eligible to get vision, eyeglasses from Medicare? So that's all Medicare Advantage. I should point out that those are really crummy versions of that. The pharmacy benefit is usually one of the most restrictive. The hearing, is pretty limited. The eyeglasses are very limited. Dental might cover two dental cleanings a year. Basically, it wouldn't cover any serious dental work. The total benefit package for those things on the right-hand column there is worth about $2,400 this year, and hardly anybody uses anywhere near that much of it. So it does cover these things that are designed to be attractive to healthy people, right? Nobody's going to join a Medicare Advantage plan because they wanted a gym club if they're disabled with some expensive illness. So the perks on the right tend to be relatively low value and tend to be attractive to people who are healthier, but they are perks. They are perks. The network in Medigap, if you have traditional Medicare and you join Medigap, you don't compromise anything about the network. You can still see the full range of physicians. I think I showed you last time that you can see 89% of outpatient physicians, adult medicine outpatient physicians across the United States, anywhere in the United States. You know, you're in Austin, you're vacationing in Florida, you still have the full Medicare network in Florida if you're in traditional Medicare with Medigap. Medicare Advantage, it's not the case at all. I haven't looked specifically at Medicare Advantage plans in Austin to see how many of them cover healthcare in Florida, but I'll bet you that it's like most of them, and they don't. So that's out of network, which may not be covered at all, or at least not as generously. Utilization management, the step therapy, prior authorization, all the stuff that most of us patients and physicians hate, rarely happens in traditional Medicare. Medigap plans do not introduce that, any more of that at all. Whereas Medicare Advantage, this is where all these secret coverage rules we were talking about. But the reason people make the decision to join Medicare Advantage is really simple. They look at $200 a month versus $18 a month, and they go, hey, I heard that wacky Dr. Weisbart talk about this stuff, but I'm healthy. What do I care about, these other things? I'm healthy. I'll just do this. I'll do Medicare Advantage for a couple of years, or whatever, I'm 65, I'll do it until I get sick. And when I get sick, when I'm 70 or 75 or whenever that happens to me, if he was right, and if the Medicare Advantage company won't let me go to the doctors and hospitals that I think I need to go to, well, then I'll get out. I'll just get out. I'll go back to traditional Medicare and I'll buy a supplemental policy because I'm worried about bankruptcy. So I'll, go get a supplement, and then, fine, I'll have saved those premiums for a few years. Well, what they don't know is that they may not be able to do it. So it is true that you can leave Medicare Advantage and go back to traditional Medicare whenever you want. That's true. Maybe once a year. I don't know if, you can do that pretty easily. But it isn't true that you can rely on getting a Medigap policy. It isn't true that you can rely on getting Medigap. So this is what most people making this decision don't realize. We all think that these protections from the Affordable Care Act apply to Medicare, but they don't. They don't. So, in Medicare Advantage, in the Affordable Care Act, part of that was the elimination of bans on pre-existing conditions. And that's called guaranteed issue. So that if you want a policy in the Affordable Care Act, they can't ask you a health survey questionnaire. They can't tell you, oh, no, we're not going to sell you a policy because you're too sick. The ACA banned that by creating guaranteed issue. Guaranteed issue does not apply after you've been in Medicare for 6 months, Medicare Part B for 6 months, or 12 months in Medicare Advantage. And if they do sell you a policy, you want it to be community rated, so that they can't charge you 16 times as much based on your having had hypertension or diabetes. So guaranteed issue and community rating, basically eliminating the impact of pre-existing conditions, those are protections that we expect because of the Affordable Care Act, and that do protect us the first 6 to 12 months that we're in Medicare. But after that, they disappear. So if you're in Medicare Advantage for 12 months, you may be trapped because you may not be able to find a policy, an insurance company that'll sell you a Medigap policy at a community rating. There's a handful of states, not Texas or Missouri, that have regulated it to give you more of those protections. But most places in the country, if you've been in Medicare Advantage for 12 months, you may not be able to get back out in terms of buying a Medicare supplement. Why does this exist? Why are these gaps all? Why do we even have this issue? We have this issue. Why does Medicare have copays and deductibles? Well, I think there's 3 reasons this happened. One is what's called the moral hazard. When Medicare was first enacted, there was some discussion about whether if you give everybody access to healthcare, that then they're just going to all get healthcare. And so the cost of Medicare was going to go up. That's called the moral hazard. If you make ice cream free, everybody's going to eat more ice cream. It's called the moral hazard. And the titration against the moral hazard is this notion of skin in the game, which is a pretty awful thing to say in healthcare, but skin in the game means, well, make you pay for it. If you have to pay some for it, then you'll be a more judicious consumer. That's wacky in healthcare. I mean, it's been shown that the moral hazard in healthcare, people getting more healthcare services when they get insurance, that's all stuff that's medical. It's almost all stuff that's medically necessary that they just couldn't afford. So the moral hazard is actually a good thing. Don McCann from PNHP said a couple years ago, we don't actually have to worry about unleashing a stampede of free leg amputations or free liver transplants. It's just, so Medicare has these things built in. And one of the reasons it has these copays and deductibles is perhaps because of this. That was a lot of the discussion in 1965. Another part of the discussion was, the insurance companies really opposed the passage and enactment of Medicare. And so creating these gaps, creating a niche for Medicare gaps policies, supplemental policies, made the insurance companies not quite as a little bit less strongly in opposition for it, and sometimes actually agreeing with it. So it created a niche. And the lesson there is when you hear people ask, well, gee, we can't destroy the insurance industry with Medicare for all. Can't we do some way to preserve it? Yeah, you can create a niche in the insurance companies in Medicare for all. The way to do it is to make Medicare for all crummy. To put in massive copays and deductibles and limit what it covers and stuff like that, then yeah, there'll be a niche for the commercial insurance companies, but let's not do that. I'm not actually sure that those two arguments, the moral hazard and the niche for commercial insurance, I'm not sure that those were actually the biggest drivers of why Medicare was built the way it was, because there's a third thing that doesn't get talked about nearly as much, but I think was really a big part of it. And that's called the Southern strategy. In order to get white folks in the South on board with having universal health care, they didn't want this. Remember, Medicare was enacted in 1965, 1 year after the Civil Rights Act, 1 year after the Civil Rights Act. So I don't think people realized that Medicare would be successful in integrating hospitals when they passed it. But thousands of volunteers made sure that hospitals got integrated when Medicare was enacted. So there's that. But the outpatient side, nobody thought that you could deal with that. So there were people complaining, I don't want them whole colored folks next to me in my waiting room. I shouldn't do that bad accent, sorry. But there was a big discussion about this. And so having a 20% copay for outpatient services guaranteed that it would be more unlikely to have doctor offices get integrated. And frankly, even with Medigap, that doesn't change because Medigap policies are largely unaffordable for low-income folks. And so it's lower-income folks that are more likely to go into Medicare Advantage these days. So it created a niche for profiteering. We showed you that traditional Medicare has a roughly 2% overhead. We showed you that Medicare Advantage has a 15% overhead. These supplemental policies have a 22% overhead, which is kind of outrageous. And then the last thing I wanted to talk about with you, if time permits, is to talk about this new attack on Medicare. So here's Medicare Advantage with roughly 50% of the book of business that you have to kind of usually sign up for on your own because you were attracted by the gym club memberships or what have you, and you were attracted by the $18 versus the $200, which I showed you is kind of bait and switch. And then there's traditional Medicare. Well, traditional Medicare doesn't have much of an opportunity for the investment community to meddle in. And so under President Trump, they started this new thing that was called direct contracting and has been renamed under President Biden ACO Reach. And this was introduced with the intent of ACO Reach or something very much like it, capturing the other half, 30 million people from traditional Medicare who were supposed to be in ACO Reach or something like it by the year 2030. The Medicare website says that they wanted 100% of people from traditional Medicare in ACO Reach or something like it by the year 2030. What is this? This is, as I was alluding to, new middlemen in traditional Medicare. Medicare is currently, it's still live, going through their billing history and determining who they think is your primary care physician in Medicare. And then if your primary care physician has a contract with one of these new outfits, Reach ACOs, then they assign you without asking you or by your leave, maybe telling you, but certainly not asking you, they automatically assign you to one of these new outfits. And then they prepay this Reach ACO for a range of services. So it's very similar, not the same, but it's very similar to Medicare Advantage. And it's similar also in the sense that the less services you get, the more profitable the Reach becomes. Now, it's different from Medicare Advantage in that you're not actually compelled to stay in there. You still have access to the full range of services and the full spectrum of doctors and hospitals, but the ACO Reach doesn't want you to know that. And they're going to do their best to kind of get in your way and keep you from getting things. So the less healthcare you get, the more profitable the Reach becomes. And, Medicare has said over and over again that patients can, of course, leave. Yes, we're assigning you to one, but if you don't like it and you want to get out, of course, patient, you can get out. You just have to pick a new primary care doctor. And lately what we're seeing is patients calling and saying, I want to get out. I don't like this model. And Medicare is saying, oh, okay, yeah, we'll take you out and we'll, no problem. You're out of the ACO Reach and we'll send you a letter confirming it. And what they send in the letter is to confirm that they'll no longer send their data to the ACO Reach, but the ACO Reach is still capitated and at financial risk for you. So you can't really get out. You can keep your data from being shared, but that's not what people are concerned about. They're concerned about having their healthcare be influenced by a profiteer, essentially. This happened and is happening without congressional oversight. It's a little branch of Medicare that's able to do this without having to tell Congress or get Congress to approve it. It was on track for having everybody from traditional Medicare or something like it, having everybody from traditional Medicare by the year 2030. It, as of today, has 2 million of the 30 million have been assigned to one. Like I said, on track. Here's why this is really kind of a good news story. So we started raising public outcry about this about 1.5 years ago, and the public outcry has been compelling. So a few weeks ago, Medicare announced that because of the public outcry of this injustice of damaging our program, that it's frozen, that it's not going to go beyond the 2.1 million. They're not expecting it to grow beyond 2.1 million. They're going to actually end it in the year 2026. They're not taking any new companies in. So, activism and advocacy work actually made a difference. This is really important because this program I showed you the 2%, 15%, and even 22% overhead for Medicare supplemental. Medicare Reach, these new outfits, if they get capitated, and if they spend as much as 25% less than their capitation on healthcare, and they can retain all of that first 25% they reduce for their own overhead and profits. And if they go beyond that 25%, they can retain a portion of that as well. So it's a lot of information. There's more information at PNHP's website or at protectmedicare.net. Go to protectmedicare.net. A lot of information. We'll hang
All
on for
right.
this.
Oh. Okay. Well, thank you, Dr. Weisbart. Okay, so real quick before we move on, any major pressing questions anyone would like to ask? Person or on Zoom? No? Okay, well, thank you, Dr.
questions.
Weisbart. Oh, never mind, we do have a question. I lied.
You'll have to repeat it probably.
Okay. Hi, can you hear me?
I can.
Okay. So I just had a question about, so obviously when we're talking about the coverage that Medicare is giving, we're talking about health services that you receive. Where do the cost of medications fall into this? Or is your pharmacy insurance, medication insurance considered completely separate in that it can have a completely different deductible, out-of-pocket max, et cetera?
Yeah, it's a really tragically complicated but important piece. So first, there's two broad categories of medications. There's injectables and inpatient stuff. So if you go for a chemotherapy infusion or whatever, that's all considered under Medicare Part B. So that's in traditional Medicare. So that's the injectable. But I think what you're probably alluding to is, oral solids, pills. You go to get your blood pressure treated or your insulin or whatever. Go to the retail pharmacy. It's probably, I imagine, what you're thinking about when you ask that question. And that stuff is not covered. under traditional Medicare. When Medicare was enacted in 1965, there was no pharmacy benefit beyond the stuff that I was talking about inpatient or office infusions. So Medicare Part D was enacted about 15 years ago, 20 years ago, something like that, 20 years ago, I guess, something like that. Medicare Part D was enacted by Congress as a separate portion of Medicare. And it's optional. You pay a premium, you choose it, you pay a premium for it. Then depending on which company Medicare doesn't run it, right? Medicare is the law precluded Medicare from even negotiating the prices of drugs. The law, Medicare Part D said the federal government can't negotiate the prices of drugs. So there's these, dozens or hundreds probably of different insurance companies running their own drug benefit. It's called a Medicare Part D. And every one of them is different. Everyone has their own drug list, their own formulary, their own copay design, their own everything. So you try to pick the one that you think is going to match what you're likely to be plagued with in terms of illnesses over the next year. So those are all different. So if you're in traditional Medicare, you should do what I did, which is to purchase a drug benefit, and then you can use the pharmacy with some coverage. And I spend, I think, about $40 a month on just the pharmacy benefit. Medicare Advantage, I think virtually every Medicare Advantage company today includes a Part D plan within their structure. So if you sign up for Medicare Advantage, you don't usually have to buy a Medicare Part D separate apart from that. Is that what you were asking me?
Yes. Yes, and so we have one question in the chat, and then we'll get to you. Okay. So Dr. Weisbart, I don't know if you saw the question in the chat, but it says, Can you talk a bit more about what advocacy and organizing against ACO Reach looks like?
I can. It's been really fun, actually. It looks like fun, to tell you the truth. So, it was sort of like a greenfield because nobody knew about this program. PNHP got wind of this in 2021, and we studied it and learned about it, and then we kicked off our campaign, our advocacy campaign, by going to Congress. So a handful of us flew off to DC and met with, and I'm here to tell you, none of them had ever heard of this program before. So that was kind of fun, and that got some press and so the advocacy that we've been doing has been focused around education, both among physicians who still don't know about it generally, and med students, and then the community. And then reaching out to Congress and legislators. So we've written lots of letters to the editor and op-eds. I had a whole bunch of press coverage, and with the point of trying to get Congress to act on this, because it doesn't have to have congressional approval. Medicare is able to do this on their own without congressional approval, but Medicare doesn't want to do something that really angers too many Congress folks. So we've had dozens of members of Congress write letters to Health and Human Services saying, hey, stop this. We don't want this. Shut this program down. So there has been town halls where people have been complaining about it. There have been meetings with, one-on-one with legislators. There have been all sorts of media coverage for it. And frankly, Medicare was expecting that they could do this innovation, so to speak, under the radar without anybody realizing it, but then just sort of quietly have it take over. That was really what they were expecting. And we put light on that dark spot. And in the head of the Medicare Innovation Center that runs this, about a month ago or so, has declared in public in more than one setting that because of this public outcry, because of all the op-eds and letters to the editor and noise they're getting from Congress about it, because of the public outcry, that the program is going to end in 2026 and not grow, no new entities, and expecting it to stay at 2.1 million. So does that mean that the advocacy work on ACO Reach is done? No, it doesn't, not by a long shot. Because number one, there's still 2 million people in it. So, number one, we're concerned about that. Number two, as soon as we take the spotlight off of what they're doing, they could tomorrow, there's nothing in writing that says they have to stay closed. They could tomorrow say, hey, we're going to reopen it. We're going to let more in. They could tomorrow start assigning more Medicare members into it. They could do, or what I think is more likely is they can take bits and pieces of the ACO Reach program that we so despise and sprinkle it as little harder to recognize parts within traditional Medicare. Or they could create some third program. As I mentioned, this was created called direct contracting, or DCE, under the Trump administration. And then because of the public outcry, they rebranded it to equity wash it so it looks like a better thing. We could have that whole discussion. That's nonsense. But they rebranded it from DCE to ACO Reach. And they could rebrand it something and give it a third name in 2027. So, call it Reach 2.0. So those are all things we have to keep watching for. That's stuff that advocacy needs to continue to fight against. And what does advocacy look like? It looks like community education. It looks like letters to the editor. It looks like public education. It looks like communicating with Congress and just making it known that this is not acceptable. Is that what you were asking? Yeah. It's really fun. I mean, we don't, in healthcare advocacy, you don't get a win terribly often. These are often long struggles. So, we didn't end ACO Reach, but the difference between them being on track to have 30 million people, all of traditional Medicare, versus having only the 2 million, that's just something worth celebrating. And that looks like the high sign that I should move on.
All right. Thank you again, Dr. Weisbart. And then if you don't mind sticking around maybe in the next 10 minutes, if someone has a question at the end, we can come back.
I can do that.
All right, cool. Thank you. So we're going to get into the next part real quick, and I'm going to talk literally for like 10 seconds about this one slide. But basically, to kind of set up the next part, we're going to talk about the idea that labor produces capital and both hold power. So the idea of organized capital is that it is wealth. It is the kind of employment of money to achieve political gains. And one way to think about this is the American Medical Association and kind of the amassing of wealth that they've done, and the way that they have used that to actively stop reforms for Medicare for all and single payer systems. But organized labor, on the other hand, I know when a lot of y'all think about that, you think about unionization. And it has resurged post-COVID, and there's a lot of history behind the anti-labor movement tearing down organized labor. But organized labor requires solidarity. And even if capital seems powerful, so can organized labor. So I want you to think about just these relationships, particularly, at the top, labor produces capital and both hold power. So with that, I'm going to turn it over to our next amazing speaker. Let her introduce herself for y'all.
Thank you. Hi, everybody. Thank you for that perfect segue, because I guess a lot of the lecture so far has been about, okay, let's look at the system and what the problems are with it. And my goal here is to kind of start talking about the steps we can take to change it. So my name is Kellen Gildersleeve. I use she, they pronouns. And I'm excited to be here today to talk about some of the steps we can take to ensure health equity for our patients and ourselves as workers in the healthcare system. Or even without. Dr. Weisbart had talked about how insurance companies deny necessary care, and who is the most likely to get denied that care. It's going to be our poorest patients, and it's usually going to be our Black and brown patients. So patients and their providers are so disenfranchised from any say in how this critical system functions because it's in capital's interest that happens. And it's not that they're necessarily evil. It's just that is in their interest. It's how the structure of their organizations are set up. So I always like to make that distinction. I'm not just saying like, oh, these people are necessarily here to wreak havoc and destruction. It's just like they're stepping in and saying, I'm okay with this, and continuing forward. So it's broken, and it is appalling and ends up being classist and racist. And I know that whenever we are becoming providers, we don't want to be in a system that is like that. And I want to talk about some ways that we can change it. So I have worked on a high-risk labor and delivery unit here in town for 9 years. And for the past 3, I've been a maternal transport nurse. And that essentially means if there's really sick patients at other hospitals that need to come to our high-risk unit, I go and I get them. Last summer, the nurses at our facility voted overwhelmingly to join the largest RN union in the country. And this is really huge for nurses in Central Texas who, like most healthcare providers and healthcare professionals, are feeling the oppressive crunch brought about by decades of purposeful understaffing of hospitals and clinics for profit. And it's also really huge for our patients who have some of the worst healthcare outcomes in the country, particularly when it comes to pregnant patients and their babies. I was the first nurse from our hospital to contact our parent union, who's National Nurses United. And for me, one of the main draws to this union was their history of Medicare for All advocacy. They campaigned really hard for Bernie Sanders for both of his runs. And that was specifically because of his support for Medicare for All. And in an ideal world, our professional organizations such as the American Nurses Association or the American Medical Association would be doing this kind of advocacy, but due to their financial and political associations with capital or healthcare executives, this has not historically been the case, and they typically fight against Medicare for All, unfortunately. Regardless, I'll argue that the democratic nature of unions places them in a better position to advocate for big changes in our healthcare system anyway. In the first lecture of this series, Yosha briefly discussed the different types of power we hold in society. So I want to shift a bit and kind of zero in on specifically our power as workers is one of the strongest tools that we have to fight inequity. The only reason our fragmented healthcare system functions at all is because of the dedication of doctors, nurses, social workers, and patient care technicians and other ancillary staff. When these workers come together, we can send powerful messages to the decision makers, whether they are elected politicians or unelected healthcare executives. And by acting collectively, our concerns can be addressed and our demands amplified. When we can blast them with emails, we can do letter writing campaigns and petitions. This is a good way to start out advocating and organizing, essentially by asking nicely and then hoping somebody that's already in power makes the right decision. And then we could escalate to holding press conferences to essentially publicly shame them for abandoning their responsibility to the community. And we can protest outside their offices and their homes and picket outside of their workplaces. And when all of that likely fails, we can exert our power in the most tangible way possible, which is by withholding our labor. Work stoppages or strikes are an incredibly effective tool for interrupting the cash flow that administration relies upon to continue business as usual. Strikes are technically possible without union protections, but most workers feel a lot safer striking once they are unionized. A lot of healthcare professionals are also uncomfortable with the idea of striking because they know how important the care they perform actually is to the community. I am here to argue that the critical nature of our labor is exactly why having the ability to strike is so important for us. Essentially, when you strike, you're holding a firm boundary that you will not continue working under conditions that are abusive. And your therapist would be really proud for setting that firm boundary. So I hope each of you can examine any feelings of hesitation that you have about the idea of striking, because coming to terms with this idea, I think, is one of the most important steps for conceptualizing your own power as a worker, whether you're a doctor, whether you're a nurse, or whoever you may be. It's the place where you have the biggest influence in the world besides your own home. And so I always like to kind of zero in on that and be like, it's hard to wrap your mind around the power of a union if you're not willing to think about the idea of a strike. But the next step after that is, if you think that this is the way to go, then you want to understand how organizing works and how you organize people. And a lot of people will turn their noses up at this part and kind of call it politics, but I would encourage you to think of it more like influencing, because influencers are change makers. But in your case, instead of influencing people to buy a bunch of stuff they don't need, you will be influencing them to take back their power and show up for each other and their patients. So this is essentially just being there for your community. There are a lot of free resources out there that can get into the nitty gritty of exactly how to successfully organize your workplace. These can be found at labornotes.org, workerorganizing.org, or organizing.work, 3 different separate organizations that work together in coalition to help give people free education on how to organize their workplace. But I want to give just a quick overview to demystify the process and make it feel more accessible to those in the healthcare field who are already stretched really, really thin. So step one, when you enter your workplace or in the workplace that you're already in, I highly recommend that you create strong social connections with your colleagues, learn what issues drive them both in the workplace and personally, learn who's friends with who, especially those who are friends with management or looking to promote to management roles, because people in management can't be part of your bargaining unit. And it's good to know what people's interests are in terms of the trajectory of their careers. Do your best to avoid alienating powerful colleagues that are leaders. These natural leaders will be your biggest allies in the change-making process. And once you understand the formal and social systems of your workplace, then you'll be ready to start organizing. So you and your colleagues will have a choice of forming a new union from scratch or joining a well-established union. There are pros and cons to each of these choices, which I won't get into today for the sake of time, but it's an important distinction whenever you're trying to determine the goals of your union and also kind of the environment that you're organizing in. Then you'll just make a list of everybody in your workplace, and you and your colleagues that are organizing with you are going to systematically go through and gauge support and take notes. A lot of people recommend starting a shared document where you've got everybody's name and then whether they are satisfied with the workplace or not, and then the major issues that they want to change. And then once you kind of look at how many people are in your workplace, and if you've got the majority of them interested in making changes, then you can start talking about how we would make those changes. Because if you just come right out and be like, hey guys, want to start a union, that's a very intimidating idea. But if you're doing something called agitating first, which is talking to them about the issues that they're concerned about, validating that, and then saying, okay, what's the next step? What can we do? That's a much more natural, less threatening approach to an organizing conversation, essentially. So for strategic reasons, you'll want to keep a lot of these conversations as secret from management as possible. What you are doing is completely your right, and you have a federally protected right to organize. But it's more that as soon as management finds out that you're trying to organize, they will come in with every resource they have to bust your union. And anti-union consulting is a multi-million-dollar industry. There are anti-union consultants who will come in and do captive audience meetings, things like that, to prevent you, even before you've gotten to talk to everybody in your workplace, to prevent you from moving forward with your campaign. So try to be super sneaky at first, and that I think will protect you and help you kind of get further before your union gets busted. And then once you know that the majority of your colleagues are pro-union and want to get one started at your workplace, you can file for a union election with the National Labor Relations Board. You could also just ask your employer to voluntarily recognize the union. That is a thing, but even the most progressive of organizations will not do that. Like the ACLU did not do that. Their employees had to fight for their union by having a union election. So just think that's an important distinction. Like, just because you're working for a nonprofit or a not-for-profit place does not mean they're going to understand and just give some of their power away to you. So I was going to talk a little bit more about union busting, but I think I'm going to skip forward to just talking about how there have been a lot of changes when it comes to the perception of unions. For many years, my colleagues would literally shush me when I tried to talk about unions. They would be like, don't say that. Don't talk to me about that. I don't want to get around to management that you're talking about that. Some even told me that they thought it was illegal to unionize in Texas. And I think that they believe that because Texas is what is called a right to work state. Right to work laws make it harder to form unions and weaken the effectiveness of existing unions by making it difficult to financially sustain themselves. And then it's also an at-will employment state, so they can fire you for any reason. So even though it's technically illegal to fire you for organizing, they can they can audit your charts and find something you did wrong and fire you for that. And so it can be really scary to organize in right to work states, but and at-will employment states. But we can see clearly that workers in right to work states have lower wages and less benefits for their workers. So I think that the numbers speak for themselves there. I also want to talk a little bit about this idea of solidarity. So what happens? You win your union, like hopefully you get a good contract for your workplace, and then you can start forming coalitions with other unions in the city where hopefully instead of just asking for things to change, you can demand for things to change by withholding your labor until an acceptable agreement is met. And I think that's the difference between community organizing whenever you're talking about trying to elect politicians who may or may not be favorable once they actually get into office. This is a little bit more of a tangible power that people have. So the cool thing is our union is already getting to make and it's brand new. We don't even have our contract yet. We're still in contract negotiations, but we're already able to make connections with the teachers union and talk about the similar problems that we're having. And then hopefully we are able to show up for each other and kind of amplify the demands of people who are in similar situations with us, which is what solidarity is all about. And I'll just close by saying Capital is so organized. That's the reason they've been able to consolidate so much power. And they've kept us really overworked, especially healthcare professionals, because we went into this most of the time because we want to help people and we're very altruistic and we want to give and give and give. And then we get to the point that we are burnt out and we're morally injured. And that makes it a lot harder to do this kind of work. So if you can push through and get involved in some sort of organizing, that can be the cure to moral injury, is making reparations and trying to fix the injustices that caused you to become morally injured after seeing unjust things happen to your patients and your coworkers day after day. It is really an exciting time in labor organizing in this country, despite union membership reaching an all-time low last year. There has also been a huge surge in formation of new unions. COVID opened the eyes of many workers to the fact that their employers need to be held accountable. And people are using the internet to have ongoing conversations about worker rights and worker organizing all over the world. Young people are a huge part of these and are increasingly becoming politically engaged. So I think if we all work together and build multidisciplinary coalitions, I know that we can win. And whether we're winning sufficient pay to live in the cities in which we practice, all the way up to hopefully achieving victory for Medicare for all. That's it. Anybody have any questions? Thanks, y'all.
Yeah, thank you. Let me check if there's any questions in the chat. Okay, cool. Any other questions in person? Yes, is Dr. Weisbart still here? You pin him. All right, cool. Yeah, one more.
Well, thanks. So I had a comment about Dr. Weisbart's part, but I also wanted to ask Kellen a question. So maybe we can start with Kellen's question first. So can you talk a little bit about, so there was Nurses National United, this like established union that you felt really connected to. For people who are not nurses, what does it mean to unionize when you might not have something like that to connect to? Like, are there physician unions that, I'm assuming other people here are like med students or more in that kind of track. Like, what does that look like for folks who don't have such an awesome union to tack onto?
Thank you. I really appreciate that question because I actually meant to talk about that specifically because there's probably medical students mostly here. One of the things about a person not being able to have a union if they are in a supervisory role is actually a lot of doctors, once they are out of their residency, do end up being in some sort of supervisory role and not able to unionize at that time. However, there is many years whenever you are in residency that there are physician resident unions out there. And forgive me, I don't know the names of them, but I think that that is something that is also new because I had never heard of any residents being organized until recently. I think they're like in another state in the Southwest. I'm sorry that I don't know specifically, but it is possible. And I think it's so important too, specifically for medical residents who are some of the most exploited workers in our country, to be able to stand up for themselves. So they could form their own union. There are other unions. I would definitely do research because there is power in numbers, and joining a parent union can be really good for that, especially for people who don't have a lot of time on their hands. But I can't speak to whether I would recommend one just because I don't know one. Did that answer your question?
Real quick, the union that I believe Kellen was talking about, it's called CIR, or the Committee of Interns and Residents. And they do have kind of national association with SNAP. And so we'll include this in the follow-up email that we send out to everybody, but there are kind of like ongoing webinars and things that you can join to learn more about CIR.
Thank you. I think it's really helpful. Also, I think this was something I learned when I was at UT, that there's a UT union, and I think like, yeah, right. So like I became an RA and then I was contacted for something and I was like, hold up, there's a union at UT. So I think like there could also be places to plug into that we don't even know about. So just a plug for that for any UT students that are working in some capacity at the university. The other thing that I just wanted to mention in relation to Dr. Weisbart's part was, we had talked about like this idea of Medicare traditional with Medigap compared to Medicare Advantage. And something that I found as a social worker in hospital settings was most patients didn't know that they could be eligible for Medicaid once they become over 65. So like the idea that you could be dually enrolled in Medicare and Medicaid means that you don't have to pay copays. It covers your coinsurance. It's like a widely effective program that people don't even realize that they're eligible for. And then I can't remember, unfortunately, with the other, there's like a step below. So it's like, well, you're not eligible for Medicaid, but you're sort of poor. So we'll cover, you'll have a slightly smaller copay and we'll still cover, your coinsurance is less. So, and that's a totally separate application than Medicaid. But anyways, like just kind of connecting with social workers on your floors or in your healthcare system that might know how to navigate that system, because that is or should be our role. And I think oftentimes that's not talked about enough, that like social workers are a resource that physicians and nurses and other healthcare professionals can lean on when it comes to health insurance, which is so complicated. So just a plug for that.
All right, cool. I guess that's actually it. So thank you all for coming. And like I said, we did record this. We're going to send that out in a follow-up email to everybody. And yeah, please fill out the feedback form. The QR code is up there. It's really going to help us kind of evaluate these sessions. But with that, I hope to see you all next week, 12:30, talk about COVID.